Well, good evening and welcome to you all this evening. My name is Steve Heilman and I'm a member of the Adult Education Committee here at Bethel Lutheran. I would like to introduce our speaker, Dr. Heather Blue, who is currently an assistant professor at the University of Minnesota College of Pharmacy. She was born in Cambridge, Minnesota, and currently lives outside of Duluth with her husband and 2 daughters. She obtained her doctorate in pharmacy from the University of Minnesota College of Pharmacy in 2007. Upon graduation, she held clinical and hospital appointments at Mercy Hospital, Allina Health in Coon Rapids, Minnesota, and Minnesota Geriatric Services of Minnesota. In 2016, she joined the faculty of the College of Pharmacy and has a clinical practice in the emergency department at St. Luke's Hospital in Duluth. She was recently named Teacher of the Year at the University of Minnesota Duluth. She has also received the Outstanding Pharmacist Award this year by the Minnesota Society of Health System Pharmacists. She has published 7 research papers in various peer-reviewed journals and given several lectures like this one this evening, describing the opioid crisis within the state of Minnesota and at scientific meetings at the national level, as well as on television and various other medias discussing this problem. This evening, she will speak about opioids, the good, the bad, and the crisis. There will be time devoted for questions from the audience at the end of her presentation. If you have a question, please raise your hand and someone will bring you a hand mic like this one and speak into it like this if you would, for you to ask your question. Her presentation tonight is being videotaped and will be available for viewing on the River Channel and as a link on our church website. The availability of this on the River Channel will be on Channel 15 in Hudson and North Hudson. And also the River Channel Facebook and YouTube will have her presentation. Now, without further ado, please welcome Dr. Heather Blue.
All right, thank you. Sound good for everybody? All right, I'm just going to keep my slides up here as well as just an eye on the time. This is a topic that I'm passionate about. And sometimes I get a little wordy. So what we'll talk about today, opioids, the good, the bad, and the crisis. Giving you a little bit of background, it's kind of a potpourri of opioid facts and a little bit more education that you can take out and better understand the crisis that we're currently facing. If we look at the objectives for tonight, this is my agenda. This is what I want to be able to get through, so keep me on task. I'm going to describe a little bit about what opioids are, how they work, how they can be appropriately used for pain management. We're going to then talk about the bad part. What are the dangers of opioid overdose? I'll give you a little bit of information about the data that we're seeing, and then hopefully identify some ways that we can really try to make movement towards a solution to the opioid crisis. So let's start with the good. There are some goods to opioids. It feels a little silly as we talk about this and thinking in the scheme of a crisis, but there are some goods. If we think about what opioids are, we really have to start at the very beginning and understand what are we talking about. And you'll hear, I think I say opioids a lot. You might hear in in the media opiates. So there is a difference, and I met a plant biologist that can tell you a whole lot more about the different pieces of this, but opioids are actually from the plant. So they come from the poppy flower. If you remember in The Wizard of Oz, Dorothy's lying in the poppy field and has these solutions. So that's opium. That's where opiates come from. Now, opioids are a bigger class. They include all of those natural products, but they also include some of the synthetic ones. So once we started to realize what these medications and these compounds could do, we then created our own man-made compounds. And so those we classify as opioids. And so, again, it's kind of, you'll hear them referred to as both ways, but all of the drugs that we're talking about are all opioids. And the way these medications work are at a bunch of different receptors. We'll talk about one in more details. This is the mu receptor. We also know that there's the kappa, delta, several others that we probably even haven't found yet to really know how they're working. But it's the mu receptor that we're most concerned about. And you can see in this picture, we've got these mu opioid receptors in the brain, and they're there. Everyone has them. They are what send that signal to the brain that there's pain. We need that, right? That if we weren't to have any pain, we would put our hand on a hot stove and get burnt. Pain is a reflex that we need to have. But when that opioid sits on that receptor, it blocks the pain signal to the brain. So that's good sometimes. Anyone in here ever had a surgery? Yeah? Do you remember it? Do you remember them cutting, feeling that? Hopefully not. Because we use those medications to block those pain signals. So in acute pain, we really do want to block those signals from getting to the brain. As we think about, we can go to the next slide, is we talk about opioids and thinking about there are lots of differences within those classes. And you'll hear, and we'll talk a little bit more about them, but we have lots of different types, and how they react with this receptor are the difference between the different classes, how strong they are, how long they last. So some of our medications that we use for procedures have a very short, what we call it in the pharmacy world, a half-life, how long they're going to be there, how long they're going to sit on that receptor. Some medications, so I can give you an example. Heroin is very short. Fentanyl, also very short. Fentanyl we'll use a lot for procedures, again, because it's that short piece, but they have a short activity, and then they fall off that receptor and are eliminated by the body. We have other medications. Methadone is a great example that has a very long half-life. It will sit on those receptors for a long time. Now this slide is looking at, not only do we have how long do they sit on the receptor, but we also have their potency. So how many receptors do we have to block before we have some of those side effects, and thinking about really the potency. And maybe you've heard of some of these. So if we're looking at morphine is kind of our standard. We compare all of our opioids to morphine. You might have heard of morphine milligram equivalents, or MMEs. That's where we take any of the other opioids and we try to set a bar, and we compare them all to morphine. Then we have heroin, which is about 2 times more potent than morphine, meaning if it would take double the amount of morphine to equal heroin, and that effect. We have fentanyl, which is 100 times more potent. So again, think of that, how small that dose can be. In fact, as we think about it, as we dose, maybe you've seen prescriptions, you'll receive your morphine and it'll be in milligrams. If you receive fentanyl by prescription, which you wouldn't unless you were having it in the hospital, we'll give it to you through your IV, that is in micrograms, so a much smaller amount will have the same effect. We look at, have you heard of carfentanil? It's been in the news. It's the kind of the elephant tranquilizer. It's what our police are worried about. This is very strong. It's a synthetic fentanyl analog, so it's a lot like fentanyl. It acts like fentanyl in the body. Its chemical structure looks like fentanyl, but it is very potent. Look at that, 10,000 times more potent than morphine, and that's why we're worried. Recently, the Twin Cities had a big outbreak of overdoses, and they really think that that was heroin laced with some fentanyl. And so if you think about it, someone who has been using heroin and knows about what dose they can manage, all of a sudden if there's fentanyl in there, and that's 100, well, if we look at it, it's 50 times more than heroin, that's where the overdose happens, because it's so much stronger, more potent. You need a little smaller amount to have the same effect as what they've been using previously. Next to it on these vials are really looking at a visual of how much. So these, again, looking at potency, all of these, the heroin to the left, fentanyl, and carfentanil, this is how much that would have the same effect in a patient. So it's just that visual. You can see you need a very small amount of carfentanil to have the same effect as you would with heroin. Now, why would you want to do this? Why would you want to use a much stronger drug? Think of it as a business. If you're selling medications, you could make a supply last a lot longer if you have something more potent. So as we talk about those and we think about since some of it is too of how long they last, how well they hold on to the receptor, but also how many receptors have to be blocked in order to have those effects, and that's potency. And then as we think about where else so I said the good, and how these medications should be used, can be used. We talked about the surgery. If we're thinking about that, the World Health Organization actually has a pain ladder. They look like steps of what are opioids appropriate for, and so where should we use them? As we think about this, and I can say this is where we strive to be in the healthcare world. Sometimes we do jump the steps inappropriately, and we're not using that foundation. So as we have someone that has pain, especially as it moves from an acute, if you come into my emergency room and you've broken your femur, maybe it's sticking out, you probably want some opioids, and I'm going to want to give them to you. However, in thinking about how long you're going to need them and use them, we're going to want to make sure we have this foundation. This is when the physicians tell you, let's make sure you get ice, heat, rest, elevation, maybe some Tylenol or acetaminophen, some ibuprofen. Let's get a backbone of non-opioid care. And then if we have pain beyond that, we can move up the ladder. And so really having that foundation of thinking about, let's use what other medications we have. For instance, maybe it's nerve pain. I don't know if any of you have experienced nerve pain. It's a very different type of pain. The shooting, burning, stabbing pain. Opioids don't work real well for that. That mu receptor doesn't do the same thing within the nerves. So we're actually better off using some of these other things. Maybe it's actually an antidepressant, has some different effects on the nerve. And so we should be using those other pieces before we go right to opioids. And again, as we'll talk a little bit about being a good patient and thinking about prescribing, I want to make sure that as we talk about opioids, we aren't always thinking, no, I never want to use opioids. They're never appropriate. And we'll talk about some of the reasons why I think the opioid crisis is happening, and this potentially is one of them, that maybe the pendulum has swung too far. So now, as we talked about the good and some of the places where opioids are appropriate, we need to move to talk a little bit about the bad. So how are opioids? We know they're helpful, we know they're appropriate at times, but not always. So we've got that little mu receptor. Remember, he's sitting on the brain. It's his job to tell the brain, hey, this is painful. We need to pull our hand away from the stove. And that opioid will go and sit on that receptor, and it'll block the pain. Maybe it's not a good thing if we're not going to move our hand away. But the other thing that receptor will do, and the other message that it sends to the brain, is for breathing. Super important, right? And sometimes, if enough of those mu receptors have opioids sitting on them, and that signal is blocked, breathing stops. That brain isn't receiving that signal to say, hey, it's time to take a breath again. And of course, that's not something that we have to think about as we go through. So that is how overdoses happen. The body really forgets to breathe. That signal is blocked. And again, that's why you can take an opioid, maybe after a surgery, and you have enough of those mu receptors sitting open that are still sending your breathing message, but you get enough of them blocked, or you have a really potent drug that it only takes a little bit to block a whole bunch of receptors, and that's where the overdose, that urge, that reflex to breathe stops. So we actually see what happens in an opioid overdose is that patient will stop breathing. Now, of course, if you go without oxygen to your brain long enough, you can go into cardiac arrest. And so depending on how long the brain has been deprived of oxygen, you'll see different symptoms in your patient. But that first thing is patients will look sleepy. They may be breathing funny, so they might have really shallow breaths. It might be really odd breathing, kind of a snoring breathing. Again, that message isn't getting all the way to the brain saying, hey, You got to do this. This is, take your breath. We can go to the next slide, too. As we think about, I did jump ahead a little bit. We'll stay on this slide. But in thinking about those overdoses, so sending those signals to the brain to breathe and then having them block. So what puts us at risk of overdose? Well, we've already mentioned the higher the opioid dose, the more those receptors are blocked, the more the message to the brain is blocked. So when you use the higher opioid dose, that can increase your risk. Anything that also decreases breathing. So that can be another medication. One I think of most commonly as we talk about this are in the drug class called Benzodiazepine. They're sleeping medications. We use them for insomnia. We use them for anxiety. A little trick, they usually end in PAM, lorazepam, diazepam. That's kind of a trick. But they relax you, again, to the point where that urge to breathe is relaxed. Breathing conditions. So maybe it's already hard for someone to breathe. Maybe they have COPD, they have asthma, they have sleep apnea. So there's already a reason that even when the brain is receiving all of those messages, it's not as functional as it should be. We also know that a risk of having an opioid overdose is highest after someone has not used opioids for a while. We see this most commonly if someone is released from prison. So as you think about it, the body does very interesting things as you're using opioids. You can develop what's called tolerance. You maybe have heard that. It takes a higher dose to have the same effect. The reason is that your body is also creating more of those mu receptors. So as it's kind of revving up. However, if you stop using, those receptors kind of downgrade themselves and they become less functional. Again, where we see this most is our patients being released from prison. So they may be gone through withdrawal as they've been incarcerated. They know that prior to their time, they were able to use a certain dose of medication, whether that be prescription or illicit opioids, and then they don't use for a period of time. All of a sudden, when they go back out and they go back and use that same dose. Well, their body has reduced the number of opioid receptors that are there. So all of a sudden, maybe they had been, and this is very simplistic thought of how it's actually working, but maybe previously they were able to get by, maybe 20% of the receptors were full. And so they weren't to the point where they were stopping breathing, but they were blocking those pain signals. Well, now we've reduced the number of receptors, and all of a sudden now we're at 80% of those receptors are full and sending that message to stop breathing. That's where we see a risk of overdose. So looking at making sure those patients understand that if they choose to use after, that they're going to lose their tolerance. Same thing would happen to us. Maybe you were on an opioid medication for an injury, and you always took 2 tablets. It took 2 tablets to control your pain every 4 hours. Then hopefully your injury got better, didn't need it. All of a sudden you have another injury and you remember you have that bottle in the cupboard. You say, oh, I'll take 2 tablets. Well, you maybe have lost your tolerance as well. And so even that old dose now becomes too much. That kind of makes sense about how that tolerance works and how as you stop using, your receptors change. Previous overdose. So if you have overdosed prior, you're more at risk of another overdose. And a history of depression. And some of that is just related to what we see as we look at overdose data and go backwards and see what were those causes. Unfortunately, some of those, a history of depression and suicide are opioid overdoses. So it doesn't necessarily mean that depression is going to cause the overdose, but they are related. If we now go and think about, this is where I jumped ahead, and what our patients might look like. So again, if we think about what's happening in the brain, those receptors are blocking that signal to breathe. So we'll have that breathing that's slow or absent. When the body is not getting enough oxygen, we'll see discoloration of your fingernails. Again, you think about when you're really cold. In Minnesota, we get that opportunity Duluth still gets that opportunity, you know what that looks like. So cold, blue, kind of blue fingertips, blue around the mouth, and the lips kind of turn that blue. They may not be moving. Most likely, again, their brain's not getting enough oxygen. It may sound like they're choking. Again, they're gasping. And then the key, when you wake them, you shake them, you call their name, they don't respond. Because they're not getting enough oxygen, they might be cold and clammy. And we used to always say in healthcare, check their pupils. Because something else that opioids do is they restrict your pupils. So they get really small. You get that pinpoint pupil. Now, with the new synthetic medications such as fentanyl, that doesn't always happen. So that the chemical compounds are different enough that we don't always see that. So when I'm in the emergency room, if we see pinpoint pupils, we're going to go right. We're going to think this is an opioid overdose. However, if we don't, we might still treat them like they're an opioid overdose. And we'll talk about how we'll treat and why it doesn't matter if we're wrong in that guess. But this is what you might see in that patient. I'll switch. Thank you. I was telling Bill that I gave a presentation at the Minnesota Rural Health Conference yesterday, and I'm a little nervous that my slide sets are different, and then I'm going to start giving you the other presentation. So that's why I'm a little like, wait, what slide? So we've talked about the good, right? We've talked about how opioids are appropriate and how they work. We've talked a little bit about the bad and how they cause overdose. But now let's talk about the crisis. Why has this become such an issue within our communities? So if we first think about the crisis, we'll start at a big picture and look at national data. So this comes from the CDC, and they say that since the year 2000, 700,000 people have died from a drug overdose. If we look closer at what that looks like, 68% of those overdoses in just 2017 were opioid related. A lot, right? And then as we look at, again, that year 2017, and we look back at 1999, we see that for opioid overdoses are 6 times higher. So we ask, why is this happening? A lot of it relates back, and this puts it into, I don't know, I'm a little shocked by this number. On average, 130 Americans die every day from opioid overdose. Are you surprised at that number? I am. I think of all the things I've done today. I've had a very busy day. But while I've been active, my busy day, you think about what you've done today. 130 lives were lost to opioids. It's huge. We need to be doing something about it. And thinking about why this is working, and a little bit about the trends in what we see. If we look at, furthermore, in some CDC data and their graph, we see that there's been a steady increase in opioid overdose deaths. This is change as we look at the country as a whole. So again, I told you, we're going to go big picture and then we'll zoom in. But looking at this, so lots of pictures. Starting up at the top left, we see this is in 2003, and overdose deaths, so from the end are blue, and then as we go up and get to the more red colors, we're seeing that those numbers have increased. And you can see, year by year, the colors get brighter, the numbers go up. The end down on the bottom right, 2014, so I don't even have the graphs going forward. And you'll see some of those numbers. We've gotten a lot worse even since 2014. But look at how much of the country has moved from, so these are overdose deaths per 100,000. How much darker? And as we talk about, we'll look at the local numbers here in Minnesota and Wisconsin, and you see, look at this map, we're actually doing better than a lot of the rest of the country. So as you think about how much of a crisis we see in our own backyard, we know it's even worse outside our local area. So this is the graph I wanted to show. I was shocked when I saw this graph on the CDC website because I think we know that opioid overdose deaths have been going up, but I think you can see some clear upticks in those rates. So this graph starts in 1999, where we first saw the first wave of overdose deaths. And I don't know how much it's related. We talked a little bit earlier. Anyone ever heard of Purdue Pharma? Yeah, there's a lot of media on them right now, a lot of push. So Purdue Pharma, if you're not aware, they're the drug company that makes OxyContin. And they came out in 1996, and they had a strong marketing presence. Probably more marketing in the pharmaceutical industry that we had ever seen before. Now, I can't say for sure that's why this line increased, but I can tell you if you also look at the data of opioids and the rate at which they were prescribed, that's when it changed. So you can see that purple line, starting right at 1999, we saw a big increase in prescriptions. So these weren't illicit drugs. Most of them weren't off the street. These were doctors writing prescriptions to their patients. We saw a huge uptick in opioid overdose deaths related to those prescribed opioids. Then you can see as we go on, wave 2 started about 2010. You can see another thing, right around 2010, 2011, there's kind of another little dip down in the commonly prescribed. So that's about the time frame when we were starting to realize as healthcare professionals, oh, maybe something's going wrong here. That's when at least the Minnesota prescription monitoring program, I have to admit I didn't go and look at when the Wisconsin one started, but the history of the Minnesota one started about 2009. So now all of a sudden, our physicians were able to see what opioid medications were being prescribed for their patients by other doctors. So patients that were perhaps seeing several physicians and getting medications from several, physicians now had access. I mean, they'd always been asking their patients, hopefully, but now they could actually see those prescriptions, and they could start to have that conversation of, you're getting your oxycodone, you're getting your Vicodin, your Norco, your Percocet from me and someone else. Let's talk. Maybe you've heard of opioid contracts, narcotic contracts. That's when we really, as healthcare, decided to change our ways. And again, my opinion, I think we squeezed a little too much. We swung the pendulum. We kicked people that had been on an opioid medication for a long time. Their receptors had changed, and we stopped them. We also saw an increase in heroin about that same time. Related? Probably. As we think about these patients, their receptors, their brain chemistry needed those opioids. And they had been getting them from their physicians, and we cut them off. So if that's truly the cause, but it definitely was related, but we saw that increase in 2010. And you can see that's a steep increase in heroin. Now that isn't the only change. We also saw pathways into our country. The heroin market changed. It was all of a sudden easier to bring in heroin and to distribute. So that business really took hold within our country, and hence the steep increase in heroin. Now, wave 3 started about 2013, and I don't know about you, but as I look at this graph, that's the scariest line on here. It's the steepest, it's the greatest, it's a huge increase. If you remember back to that picture of the vials, it only took a little tiny bit. So synthetic means fentanyl. It means that carfentanil, that elephant tranquilizer. It means any other medication that people can tweak. So that's it. They take the fentanyl molecule, and again, these are people much smarter than I am and thinking about chemical structures, and they tweak just a little bit. They're very potent, and you know what else? I can't find them on my drug screens. So in the emergency department, we'll run a drug test, and we won't see them because we don't know what we're looking for because they've tweaked a little bit. There's very little regulation. We don't know what it is, and they change fast enough. Just as we get a drug test that's able to find that chemical compound, they've moved on and are making others. So we know they're super potent. They're killing lots of people. And so that's the line that really scares me as we think about where we're going and how do we solve that? They aren't coming from a physician, so we can't look at our prescribing practices. They're in the community, but how do we shut that down? As we look at the next slide, this is looking at Minnesota data. So again, the lines are, some of them just as steep, and lots of colors. So this is the new map, or the new graph from 2017. As you see, in 2017, we had 422 opioid-involved deaths in Minnesota, the highest that we had ever had. So again, unfortunately, that line keeps increasing. As we look at what that could be, so if you see on this graph, it's the orange line, kind of 3 down, is that synthetic opioid. So again, you see that huge increase, that steep line. Steep lines on a graph like this are not good. You can see for the first time in a long time that we did see a decrease in heroin-related deaths. Unfortunately, we think that since we had the increase in synthetic, that maybe it's just a switch. We're not necessarily, we're just trading one substance. We're probably trading a substance that's more potent. So again, they can use less and have the same effects. As we look at Minnesota opioid overdose rates and break it down by urban areas and rural areas. So again, I spoke at the Rural Health Conference and looking at how those rates differ. We actually see different rates in different places, if that makes sense. So if we look at the next graph, we can see that in the urban centers, we are seeing a lot of synthetic opioids. So again, there's that steep curve. Psychostimulants is on here. Although they are not an opioid, that's meth. So as we look and think about using substances together, we're seeing that increase. However, if you look over on the greater Minnesota, psychostimulants are where we've seen our biggest increase. So again, as we're trying to focus on opioids and curtail opioid use, we're unfortunately seeing our meth use increase, again, within the state. So then looking further, these have all been death rates, thinking about opioid deaths, but there's more to that story. So for each death, so this is looking back at 2016 data from the Minnesota Department of Health, there were 395 deaths, but for each death, you can see that there were 2 hospital admissions, there were 4 emergency department visits, and EMS, or the ambulance, had to go out 7 times for each death. So as we think about the cost to our healthcare system, we are not seeing the whole picture, even with opioid overdose deaths. Now, maybe you're thinking, how many of you are Wisconsinites versus Minnesota? Wisconsin? Okay, Minnesota? I'm not going to go by sports teams, because I know that's dangerous territory. If we look at Wisconsin rates, which I have to admit, prior to this, I had been focusing on Minnesota, but I thought, I can't go into Wisconsin and present just Minnesota. So I pulled your graphs. They don't look better. In fact, if you remember, we were in 400s, remember, for opioid overdose rates in 2017. Wisconsin, 916. So double what we saw in Minnesota. I found this next fact on their website as well, and was shocking as we look at data. So you can see how the overdose rates with prescription. So now we're not talking necessarily about heroin or even the fentanyl, but for actually prescription overdoses increased 238% within the ages of 10 to 24. Whoa, right? That's crazy. Think about that age group. And then as we go to the next slide, I want to remember, as we go through these numbers, and it's shocking, and we look at percentages, I have to remind myself to take a step back, that these aren't just percentages. These aren't just increasing numbers. They're definitely increasing. But these are people, and these are family members. They are fathers and mothers. They are someone's child. And even if it is one overdose death, it can be extremely significant. So as we kind of think about, yes, we see the number, and as we look through the data, it's easy to get kind of blinded by the numbers, but to remember, these data points are people, and they're people's loved ones. So we've talked a little bit about the causes of the crisis. I mentioned prescribing could clearly be a cause. Pendulum swing, so I mentioned that as well. As we really wanted to tighten opioid prescribing, maybe we swung a little bit too far. Accessibility, especially as we talk about young children getting access to medications, whether that be from friends or family members, if your access is there. Even as we talk about healthcare workers, you see the rate of substance use in hospital workers, nurses, doctors, pharmacists, because we have access to that medication. Social determinants of health are huge in thinking about low educational attainment. We know that our overdose rates are higher in areas of poverty, in areas of unemployment, and in areas where people feel isolated. If we think about those rural communities, maybe the kids in that 10 to 24, they don't have anything else to do. Substances, maybe they start with alcohol. Somebody brings an opioid to the party. That, we know that can cause an increase of use. The other thing, as we talk about addiction, and I'll probably get to this as well, but I really think it's key here, is that this is not a moral failure. This is not, initially there might be a choice to use the medication, but we have no good idea of what causes this addiction. Some people are wired for addiction, whether it be smoking, gambling, medications. Mine happens to be coffee and Diet Coke. But something happens and you're wired, you use it, and you need to use it. A lot of the patients that I work with have used medications. They don't want to use opioids anymore. They don't want to continue to inject heroin, but they feel so awful without it. Great book out there called Dope Sick, talking about that they're only using it to stop the signs of withdrawal, and we'll talk about what that really is. The other thing that I think is causing a lot of this, especially as we think about that synthetic uptick in the line, is people don't know what they're getting anymore. So things have changed with how accessibility. So you could think about, people think that maybe they're buying it off the street and they think that they're getting oxycodone, or they think they're getting Norco, Percocet, something they've had before. Maybe they think they're using marijuana or meth, and they feel comfortable with this medication. They've used it before. However, it's not what they think it is. Again, there's fentanyl within it. There's some other synthetic drug, and so they don't even know what they're taking anymore. In the emergency department, we have a hard time because we'll ask patients, what were you using? And they might say, I was using heroin. Okay, but what if there was fentanyl in it? They don't even know. The internet has changed that incredibly. Again, that accessibility. You can buy things off the internet, not know what you're getting. People have pill presses. It's amazing. If you see it, Google it. Some of these pills people make that look exactly like the prescription, down to the little numbers and the score line. It'll look exactly like what they're getting. So again, you think you're taking a Percocet like you've had from your physician, and it's something else. So that's where we're seeing that increase in overdose, or one reason. So now I've given you enough of the bad, enough of the crisis. We need to talk a little bit about solutions to the crisis. And I think that there are 5, there's lots of things, but I'll highlight 5 different solutions to the crisis. We'll start with naloxone. We'll also talk a little bit about opioid treatment programs. We'll talk about pain management and what we should be doing to better treat pain. We'll talk about opioid disposal as that relates to that accessibility. And then I can't present something without talking a little bit more about the stigma around this conversation. So if we go back and we're thinking about those little mu receptors that are sending that pain signal, we've got that high affinity. So we've got that opioid. Remember, he'll sit on the receptor, he'll block the pain signal, he'll also block the breathing signal. In comes our superhero, the drug naloxone. Now this drug also likes the mu receptor and will kick off the opioid. So in the drug world, we call that it has a higher affinity. It wants to hold on to that receptor more than the opioid does. So all of a sudden it goes and it sits on the receptor, and it's like a stubborn little kid. and it just sits there. Well, if the opioid can't sit on the receptor will then send those pain signals. We'll be able to tell the body to breathe. And again, nothing happens to that opioid, right? The naloxone doesn't come in and destroy it. It just kicks it off the receptor. But the patient will begin to breathe. So again, if we think about that patient that's having an overdose, they're hard to wake up. They're maybe not breathing. And then all of a sudden, we'll give them naloxone. And again, there are videos online. I've seen it in the emergency room hundreds of times. It's amazing. All of a sudden, the patient will gasp. That pathway has all of a sudden clicked in. Now, what happens as we think about this, a couple things. So, what happens if there's no opioid sitting on the receptor and we give them naloxone? Nothing. There are very few drugs that I'm able to say the side effects are almost nothing. The naloxone will go and sit on the receptor and nothing will happen because, again, there was no pathway that was being blocked. So that's great. We can use it over and over if we need to. It doesn't work any differently. It'll just bump those opioids off. Now, the trick with naloxone, as we talk about it, as we talk about the dosage forms, you'll notice most of them come in packs of 2, is because it doesn't harm that opioid. So it'll sit like a stubborn toddler on the receptor while the opioid floats around. Well, like any other drug, at some point, naloxone breaks down by the body and is eliminated. If, you remember me telling you that sometimes the opioids hang around in the body longer, if it's still hanging around the body, it'll come back and sit on that receptor. So that's why you can see people will re-overdose. Now, they haven't used any more opioids in the meantime, but what was circulating will come back in and sit back down. So things, again, that are longer acting, anything that's like OxyContin, that's controlled release, are made to be long acting. But we'll see a re-overdose, you'll see symptoms come again. So in thinking about those, we'll talk a little bit about the types of naloxone. So we've got 2 main ways, 3 I guess, but one we won't use in the community. 2 main ways to get naloxone into the body. So again, now think of this patient. They are non-arousable, either not breathing or not breathing adequately. We can do intramuscular, where we inject the drug into their muscles, and then it gets into the bloodstream and can rip that opioid off the receptor, or we can do intranasal. Naloxone is, even though these aren't people that we're going to want to try to give anything orally anyways, but even if we would, it's not absorbed by the body. So these are 2 routes. And the third that I hinted towards were intravenous. So in the emergency department, if we have an IV, we can put that in there as well. But again, if we're seeing opioid overdoses in our community, this is what we're going to want to do. We want to get the drug in the body as soon as possible. So you may see these intramuscular, we can go on, that's fine. Thinking about, we have 2 versions, and the first are these vials. And so they'll come in vials or ampules. They have to be drawn out of the vial. So as we think about, as I educate my pharmacy students about how they should dispense this product, it's really important. You need syringes, right? This is going to do you no good if you have a vial and no way to get it out. So in thinking about it, I always tell them, please don't let them leave the pharmacy without also sending them with syringes. The kit will contain 2 doses. So again, why do we do 2? Because we might see that repeat. It works quickly, but it doesn't last very long. So we might need another dose in 2 to 3 minutes, 5. It's very variable about what other medications, what you took, how your body processes medications, and especially in rural areas, I can say probably even here, it's going to take you more than that to get to a hospital or even get to the ambulance to response. We want to be able to give people 2 of those medications or 2 dosages. The other one that was on this previous slide is a Vizio, and that's, I'll mention it just for inclusion purposes. It is in a device. It's also an injectable. It's a top one. Evzio, it's It's really cool. From a pharmacy standpoint, it's got the same drug in it. All of these, same drug, naloxone. You can see that little arrow. You pull it out, and it talks to you. It tells you how to administer it. It says, place against patient, or remove safety cap, and place against patient's thigh. Press down and hold for 5 seconds, and it'll count for you. Great for the community, right? For people that have never administered medications before. Because for all of these medications, who is administering the drug? Somebody else, right? It's not the patient. Remember, the patient is the one laying either not breathing or not breathing well. So it's super great tool, although the drug company knows it, and it's over $1,000. So I've actually kind of quit talking about a lot of the mechanisms because it's just so unattainable for a lot of people. And then the two that do intranasal, so we have the here in the yellow box or orange box, is actually the product that we'll use in the hospital IV, but we can put that little white piece on the end of it, which makes the medication that is a liquid into this fine mist. So as we stick it in their nose and squirt the medication in their nose, it will be better absorbed by that nasal, the nasal lining and be able to be absorbed into the system. It's a great med, fairly inexpensive, but you can see there's lots of pieces. And think about, again, what this looks like. You have the patient that's laying there not breathing, you're not breathing well. You have someone that's come upon them, maybe it's a family member. How do you think that is? Stressful? I even think about that with the needles and the syringes. How comfortable would you be? I drop medications and syringes a lot in my job. But in that situation, high risk, high stress, how good are you going to be with a needle? So I actually prefer Narcan. I should say, as a disclosure, I make no money or no financial ties to Narcan nasal spray, the branded product down on the bottom. And the reason I like it, and we can go ahead to that side, is it comes fully ready to go. It's this little guy in the corner. All you have to do is it comes in a package, like anything else you'd get in a supermarket. You have to open it, and it's ready to use. There are no caps. There's no measuring. You open the package, hold it like you would just like this, stick the white end. And they've done trials about, they give these to little kids, and they say, do you think you can use them? And 3-year-olds can figure out, of course, 3-year-olds, I think that's a bad test, right? 3-year-olds want to put everything in their nose or their mouth. But they can automatically, you put it in their nose, one nostril, pick one, and press. That's all. So again, in that high-stress situation, you apply it. Also comes in a 2-pack. So as we're thinking about making sure patients, and I get the question too, if you were paying attention, of the doses are different for all of these. So what's the right dose? It doesn't matter. Whatever dose you have, use it. What if it's expired? Technically, I can't dispense it to you if it's expired, but if you have it and there's someone overdosing, and you go, oh, I don't know, it's kind of like how I feel, yogurt, things like that, use it. If it smells okay, use it. Same way, some Narcan Naloxone, so Narcan is the brand name, use it. Something is better than nothing. And why do we focus on naloxone? Why am I talking about it? Number one, it works, right? That is the way you stop the overdose from happening as it rips those opioids. The other thing, the Surgeon General just put out an advisory saying, and you can read all of this, thinking about who, of course, high risk, those taking high doses, people that are misusing opioids, so using illicit, healthcare practitioners, family and friends of people that have a known opioid use disorder, and community members. We should all have naloxone. That's a pretty big statement to come from the Surgeon General. And their tagline, be prepared, get naloxone, save a life. And that's exactly, regardless of how the next steps, I completely agree, naloxone is the first step. It's a Band-Aid in the care, but you cannot rehab, you cannot put a patient into treatment if they're dead. So this is giving them the opportunity to make that next step. We think about what happens after giving naloxone. So what might that look like? So again, think what's happening. We're ripping all of that opioids off. If you haven't already, so if you're coming upon someone, call 911 if you haven't done it. Put people in the recovery position. Have you heard of what that is? We do it sometimes with seizure. Make sure they're in a safe place. You can kind of roll them over onto their side. That's because if they were to vomit, we want that to go out. If you're laying on your back and you vomit, where does it go? Gravity pulls it right back in. Then we cause more problems. So put them in the recovery position. If you're comfortable, give rescue breaths. Again, what's the problem? They're not breathing. If you can breathe for them, you're going to help solve their problem. So even if you don't have naloxone, if you feel comfortable, give them rescue breaths. So again, this is going to determine, right? I might feel comfortable if it's my spouse or one of my children. Am I going to want to do rescue breaths to anyone? Someone I turn the corner in a parking lot and see down? Maybe not. Maybe I'm not comfortable. But if you are, that can definitely help. Again, you're trying to increase that oxygen to the brain. All patients need follow-up medical care. So regardless, we need to make sure these patients are getting, and why? It's that redose or that re-overdose, right? So all of a sudden they say, I'm better, I'm fine, I want to go home. We let them go, and a few minutes later, they're in the same predicament. So really encouraging patients to get that medical follow-up. And then expect the patient to have withdrawal symptoms. So we talk about what is withdrawal, and that's the dope sickness that I talked about. These patients feel awful. So if we think about the receptor, remember the receptor it liked to have that opioid sitting on there. It was blocking those messages. The other thing is the receptors get used to that. So when you pull the opioid off, it goes a little haywire, and you get withdrawal symptoms. These are some of those, so headache, watery eyes, runny nose, abdominal pain, the nausea, the vomiting, diarrhea. If you think about some of the side effects of opioids, one we know a lot, you probably hear, especially if you've had surgery, we talk about constipation. Well, if we've ripped all of that off the opioids, these patients can have diarrhea. They'll ache. They feel awful. They'll have tremor. They might have goosebumps, even though they're sweating. They're going to crave opioids because this feels awful. And they know and their body knows, their brain knows, if we put that opioid back on the receptor, these go away. And then restlessness and irritability. And you may see some places people becoming very agitated after receiving naloxone. Now, I want to point out that could happen. That's usually not a sign of true withdrawal. Sometimes patients use opioids with other substances. So if you ever heard of a speedball, is cocaine and heroin. You use them together. Well, if they overdose and we've given them naloxone, we've stopped, we won't see any effects of the heroin, but we'll see that full effect of that cocaine, which is a very revved up, I'm losing track of the word, but you just see that very revved, you see agitation, you see kind of that fire. So we can see that, so it sometimes unmasks some of that. So again, I usually tell people, give the naloxone, make sure the patient is safe, and step back, because you don't necessarily know if they're going to have that, and I want to make sure that you're safe as a responder as well. So expect that that'll happen, and that patient will feel awful acutely. So we've talked a little bit about naloxone as a solution and how we should be carrying naloxone, especially if we have that family member or friend that we know is at risk of overdose. Let's talk a little bit about opioid treatment. Again, all of these pieces could be separate discussions, but there are a lot of treatments out there. This is a very short list, and there's also can be these interwoven. So we have abstinence programs such as Narcotics Anonymous, where these are programs that practice no substance, so complete abstinence, no substance with them. They also have peer recovery and peer support within them, so you'll have a sponsor. There's peer recovery, is that one kind of interwoven, having someone to help you navigate through the opioid treatment period. Anyone heard of drug court or opioid drug court? Couple. So this is a relatively new concept, and I think it's gaining as we start to see success stories. So this might be where a patient has a drug-related crime, and rather than going straight to jail, they can go to drug court, and they'll have a process whereby they have to meet. They usually, again, peer recovery is a big part of that. They'll have to show sobriety. They have to show work that they're moving towards. There's a lot of focus on looking at what in their life led them to this. Maybe it's a housing issue. Maybe it's unemployment. It's some of those social determinants of health. It's working to better that patient on that level versus just sending them straight to jail. So lots of really great results coming out of there. And then medically assisted treatment or medical assisted treatment. As we think about that, that is somewhere where we're going to use a medication to help with the treatment of opioids. So maybe you've heard Suboxone. So Suboxone is a combination of an opioid and naloxone together, where we'll give that, it's a long-acting opioid, and by giving that, we're going to sit on those receptors, but we're going to do it carefully so we don't cause overdose. Sometimes we'll use it short-term, sometimes it's long-term, and some patients need lifelong. So whatever it is, again, we don't understand all of the reasons chemically of why that is, but we need to make sure that at some level those receptors have opioids on them. These are always part of a comprehensive program. So they will be receiving counseling. They will be hopefully comprehensive. They'll be, again, looking at those things within their life. What does their support system look like? Do they have a place to socialize without drugs? That's important if you think about another drug, alcohol. It's really hard if you're trying to stop using alcohol when all your social networks want to meet at the bar. So how do you find a new social network that maybe doesn't have some of those triggers? I mentioned buprenorphine. That's the medication in Suboxone. Other programs use Methadone. So again, that's a long-acting. We can use lower doses and just kind of block those receptors so that we don't cause withdrawal, but we're not also causing all of that, the euphoria and the really good part of the opioids that are going to cause to want to use more. We also know that medication-addicted treatment is very controversial. So some people do see this as you're just trading one drug for another. What's the difference? Again, a lot of patients have said if they're on a program of medication-assisted treatment, they're in that comprehensive program, this allows them to get their life back. They're allowed them to get to the level where they can hold a job. They can reestablish connections to family members. And we also know from the healthcare side, and we're getting better at educating our providers, but if someone is on one of these medications, how that might affect when they do come in with a broken bone, and we need to adjust their therapy. Also thinking about opioid prescribing is really one of those things we talked about what we can do and thinking about how we use opioids for pain management. We know that it shouldn't be first-line therapy for everything. So we can do that as patients, that we shouldn't automatically ask for or expect to receive an opioid. We should try that bottom step of the pain ladder. Let's try other things before we move up. Now again, sometimes you have a bone sticking out, we move up a little bit faster. We also know that it should be for acute pain. We don't understand the reasons why addiction always happens, but we know that patients, as it takes about 5 to 7 days for most patients to start to change your receptor patterns. So if we can use the short-term medication, or as short as we can, a short course, we're better off. Our risk of having addiction is going to be lower. So we're asking our providers in the ER and surgeries and other places, if it's something that's going to heal, it's very acute, 7 days max. If patients have to come back, we'll reassess them and we can provide more, but let's start with a short course. So this is that morphine milligram equivalence, limit the MME. So if we're going to use opioids, let's use a small amount and see how patients tolerate versus giving, I don't know if you've ever had a surgery and you've come home with way more pills than you need. We've targeted and looked at, studies have looked at dentists actually are high prescribers of high quantities. And so, and there's lots being done within prescribing and looking at that. We also know that we should taper chronic opioids. So again, if you've been on it a long time and they're not working and you feel like you need to go up on the dose, maybe we actually need to go down and get you on something completely different. We're finding that what we thought was true about opioids being really great for long-term pain doesn't pan out. If we're going to prescribe opioids, we should also be thinking about prescribing naloxone, making sure that you have that reversal drug handy. Again, all it takes is a cold, the flu, you're not breathing real well, you take your usual dose, and you can have an overdose. And then I mentioned that benzodiazepine, those are those sleeping medications. We need to look better as healthcare providers as we're prescribing an opioid, that we're limiting this combo as much as possible, knowing that this is a great increase. So this is great. This is a lot about prescribing. And you're like, well, I don't really have a whole lot of control about that. So you might be asking, what can you do? What can you take away from tonight in order to help control the opioid crisis? And I'll give you a couple ideas. The first one is to be a good patient. To expect some pain. If you look at the data out there of looking at the use of opioids and the use of pain medications in our country versus other places throughout the world, it's crazy how much more we use. Why? Should our pain be different than someone else? So expect some pain with small procedures. Know that it's probably short-lived. Use the lowest amount possible. So if your bottle says take 1 to 2 tablets every 4 hours, try 1 tablet. If you need to go up, within your prescription, go up. But start with that. Expect a little. Use those alternatives. So remember that bottom step of the ladder. If the doctor says, make sure you're taking your ibuprofen with it, use that. You'll be amazed how we're going to hit different receptors, different types of pain. You'll see a lot more improvement. Other things like physical therapy, yoga, exercise, all of that has effects on your pain and very little side effects. We know that we should recognize those risks. So if you do have an acute pain, maybe you go in and you have broken something and you know that you're on a sleeping medication. Remind the physician, hey, is this going to, or the pharmacist, is this going to interact with my sleeping medication? Oh, yeah, you're right. Maybe I want to decrease a dose. Maybe I want to hold something. Maybe I want to try something different. You know that now. You've got that information. Ask for naloxone. Some places are making it the recommendation that for every opioid prescription that's written, you'll automatically get prescribed naloxone. If you do, fill it, have it available. If you have, the other thing is we talk about grandkids, young children in the house. It maybe isn't your overdose. Maybe that's accessibility. It doesn't hurt to have naloxone available. Again, you'll have that tool to give them exactly what they need right away. That's what the ambulance is going to come do. When you call 911, they're going to give the person naloxone. And again, the risks are very minimal. So if that's something where you know you have opioids in the house and you have young children, have that available. And then dispose of unused medication. I don't know how many of you, I won't make you raise your hand, are guilty and can think that you probably have some opioids in the cupboard right now. I'll admit, I think I do, even though I come up and present this. It's our nature. We fill a prescription, we'll save it, we might need it later. That can definitely be accessibility. So whether it's someone within your own home, it's amazing, again, to look at you hear stories of people visiting and going into bathroom medicine cabinets and looking for opioids. Again, they're dope sick in the sense that they're having those withdrawal symptoms and they want to find relief. So if you have them in your house, get rid of them. I had to do a little bit of looking to see, it wasn't very difficult to see where in this area you could dispose of. And please correct me if you know something different. But what I was able to find was the St. Croix County Medication Disposal System. You can see a list of the police departments have boxes. Use them. The Hudson Hospital and Clinic and Westfield's Hospital and Clinic also on their websites reported having boxes available. Use them. If you have old medications, whether they're opioids or not, just get rid of them. And there's lots of ways we're trying. The boxes are great too because usually then they are disposed of in a way that they won't end up in our water supply. So that's extremely important as well. The next point I want to make is a little bit about stigma. And I don't know what you came to tonight or how you came and what you were thinking about opioids and opioid use. Maybe this was the picture you had in your head, thinking about opioids. It was someone in a back alley shooting up. It's true, that's what it can be. But opioid use and opioid addiction can also look like this. It can be the elderly patient filling their med box. Again, it's not intentional. Maybe it's all of a sudden just something, it's a cold that just is that usual dose, it just tips you over the edge. Maybe it's a drug interaction that one physician didn't know what the other one was doing, and all of a sudden you are on something that causes that overdose. Maybe it looks like very successful business people in your community, people in your congregation that seem like everything's good on the outside. We know that those patients, those people can also have opioid addiction. And then I think this is the saddest piece, and I think about all of the stigma within opioid overdose, and regardless of how you feel about those people and think about, so this is a picture, it's out of, I believe it's out of Florida. It's actually grandparents. So they were found in the parking lot. Both grandma and grandpa have overdosed and are actually dead in the front seat of the car. And in the back is the 3-year-old grandson. And so regardless of how you feel about the people in the front seat and maybe the choices you feel that they've made, do it for the grandson in the back. They didn't make that choice. And now look how that is going to change that child's life. So we need to think about, as we talk about how it's what it's doing to our community, to our healthcare system, think about it on a much bigger picture and think of that little child. The next slide is a quote that I think, and I always question if I should put this in the beginning or the end as we talk about stigma and kind of what we come in thinking about. But self-reflection is a humbling process. It's essential to find out why you think, say, and do certain things, and then better yourself. So I commend you all for coming tonight and thinking about you came to better yourself, to get more educated, see what there was. And I encourage you, if you do nothing else with this information, that you take some time tonight to think about yourself and do some self-reflection. What do you think about the opioid crisis, about opioid addiction, and then how can you better yourself in thinking about that? I want to give you 2 great resources. There's so much out there right now, but if you're looking for numbers, you're looking for data, you're looking for how we can help, what's going on in my communities, depending on what side of the river you're on, 2 great websites. So the Department of Health and Human Services of both states have put together Dose of Reality on the Wisconsin side. Minnesota's got the opioid dashboard. It's where you can find all the latest data, again, what are communities doing, and how can you help? So in summary, we've talked a little bit about how opioids work. We've talked about how we can see overdose with them, what that looks like. We've learned about the medication naloxone that can reverse opioid overdose. I don't know if I mentioned as we talked about naloxone of where you can get it. Jump a question if someone's thinking about it. So I said we should all have it. So you can ask your provider. Pharmacists can also dispense naloxone without a prescription. So you don't need to walk into your pharmacy with a prescription. You can go and ask. And they have to have a protocol set up, but a lot of the corporate pharmacies already have that corporate policy. So you can go in and ask for naloxone if you want to have it. Again, if you feel that you're the person at risk of the overdose, please make sure that you teach a loved one, someone maybe that you use with, because it's not going to be you that's going to need to administer that medication. We've also talked a little bit about the overdose rates, both locally as well as nationally. And then we talked about those different things that we can do to help solve the crisis. We can carry naloxone. We can get rid of our old prescriptions. We can rethink pain management. And then if we can rethink about treatment programs and really think about how we can move forward to help these patients. Now I'd like to open it up for questions. Yeah.
I'd like to have her discuss cocaine, since it's in the news tonight, and it's a big concern. And two, I'd like to know about the onset of action between the use of naloxone intranasally versus intramuscularly, and also its metabolism.
Yeah, so 3 great questions. Let me make sure I tackle them all. So the first question was about cocaine specifically. So cocaine works very different than opioids. So if it's cocaine, naloxone isn't going to help. We do need to address cocaine as a separate issue. The second question was about naloxone and its onset of action. So it's faster. It's really close either way. It's a little bit faster intramuscularly. But the studies haven't been well controlled for either one. So there's highly variable, right? It's going to depend on which muscle you put it in. It's going to depend on whether or not you go actually into the muscle or into the fat layer and how it's absorbed. Intranasally, it's going to depend on what's in the nose. So sometimes if you think of someone that maybe has a cold and their nose is full, that medication may not absorb into that mucous membrane. Now, we're still going to try. So what we will train our students and our patients, again, if you can, try to wipe out the nose, even as you do, like as you would a little kid, and just kind of pinch and pull. Get out what you can, and then just go for it. Again, if we don't get that full dose administered, we might get enough to help and get their breathing started. Then you asked about metabolism of naloxone. That's also going to be very, very fast. So we say, if we see an adequate effect from the naloxone, I usually tell people, everyone's going to be widely variable, 15 minutes or less. It's kind of that piece. It's going to be very short acting. Now, it really, again, it depends on how many receptors are blocked. It's also going to depend on how well your body breaks down that naloxone, and everyone is so variable. And we dose based on those symptoms. So if you're with that patient and you've just administered a dose of naloxone and they've taken a gasp, and it's been a couple minutes, and all of a sudden, they're not talking anymore, it might be time to think about that second dose. Again, as I think about in the emergency department and the right dose of naloxone, I want to give them enough where they are breathing. Do they need to be wide awake? No. In fact, in the emergency department, I may not want them wide awake and in full withdrawal, because then what do they want to do? Leave. So I want to keep them awake enough to breathe, but not enough to run out of the room. So redose when you get to kind of that level where, they can be sleepy. That's fine. As long as you're watching and they're breathing, hold on to that second dose. But as soon as you hear those signs that maybe they're not breathing adequately, or you can kind of feel and say, I don't think they're breathing in, give that second dose. And there's no overdose on naloxone, again. So if you give it again and it maybe wasn't time for it, it's fine. Yeah.
If I leave here and go to Walmart and want to buy Narcan, can you give me a ballpark figure of what they're going to ask me to pay for it?
Great question. So it is variable depending on the pharmacy. The Narcan intranasal spray, the 2-pack, if you're going to pay straight cash, not run under any insurance, it's going to be about $150 is what we've seen. And those are kind of what I've done pricing around Duluth, which has been pretty similar across the state, at least of Minnesota. I think it'd be pretty similar here. So not extremely affordable. We are seeing a lot of insurance companies covering it. Again, what's thinking about kind of the risk-benefit piece of it, we're seeing the state programs, the Medicaid programs covering it. And then we also know that there are places where you can receive free naloxone. And so places around here, the Steve Rumler Hope Foundation has done a lot of work in the Twin Cities and surrounding areas to try to get naloxone in the street. In Duluth, we use the Rural AIDS Action Network are able to provide. So a lot of these places will receive grants to be able to distribute the naloxone. But unfortunately, and I should say the vials are usually cheaper, that you can probably get 2 doses for about $50. But then, of course, you're also buying syringes, which are also fairly inexpensive.
I don't know how to talk in these, but my first question that was really alarming to me is, why would a 10-year-old get an opioid prescription from a doctor? We know as parents, we have to cut back the dosage for even aspirin, whatever. So that is one of the concerns I had. And then the other thing is, if you're in a lot of chronic pain, you don't want to be that way. What would you say about acupuncture affecting those little mu receptors or whatever?
Yeah, so again, 2 great questions. Let me make sure I hit them both. Thinking about opioids in our young patients, a lot of those aren't prescription opioids. So there might be, and we've heard those stories where you have, and those are probably young adults, where the physician, maybe they're in a car accident, something traumatic, something where there is an indication to use opioids. And again, that happens and they become where they're addicted and they need that medication. So that can happen. What we see more often in that age group, that 10 to 24, is actually going to be prescriptions obtained through other people. So that's going to be potentially the medicine cabinet shopping, the finding it in the streets, within the school, on the internet. It's going to be prescription opioids potentially, but they're not going to be prescriptions prescribed for that child. Illegal use of prescription, absolutely. Yep. And then the second question was about chronic pain and considering acupuncture. I will say acupuncture has nothing to do with the mu receptors. So how it potentially works with pain is going to be very separate, which is good because you won't have any of those effects. And I fully support any of those non-opioid, try them. Sometimes maybe it's placebo. Maybe it's not doing anything, but you think it is. Who cares? Go for it. If it's helping your pain, go for it. So I fully support looking at pain management as a much bigger picture. Again, exercise, yoga, healing touch, aromatherapy. What are the risks? They're a lot lower than this, so try it. And there are a lot of we're looking at healthcare is looking at pain management in a very different light, and so we're looking at those. So I support it, but it's going to be completely different than those little mu receptors. Yep.
I think a lot of people, like that. I think a lot of people that have addictions also have mental health issues. So they have 2 problems.
Absolutely.
Maybe they hear voices.
Absolutely. So, and I think we heard you, but it's such an important point. I want to restate it, that a lot of patients with addiction may also have mental health problems. Absolutely. Absolutely. And the problem with that, too, is both are highly stigmatized in our culture and in our healthcare. So that makes it doubly more difficult for those patients to get the help they need. So I think that's exactly on that, that we need to be looking at that. As we talk about opioid use, that's a very small subset to a much bigger issue, and mental health plays a huge role.
You mentioned that there's changes going on with respect to pain management. The whole 0 to 10 pain scale issue is one that I guess you could say it's near to my heart, because my mother-in-law, who's 92 and doesn't live anywhere near here, so she's not going to hear this, has basically 2 levels of pain, 0 and 10. And that puts the doctors in a really difficult position, because if you report that your pain is a 10, what
We
do
have
they-
to do something about it.
That's my point, yeah. And yet you have to use some judgment, and if she says her knee pain is a 10, but she walked in, what do you do?
Yeah, so something I didn't get into as we talked about causes, and if you want, you're really interested in this, or you want to learn more, catch me afterwards, or I'm happy to give you my card and tell you some great books that are out there. And one is talking about how we look at pain in healthcare. In the 90s and the early 2000s, we were accredited based on how well we looked at that number. Did we decrease your pain score? Did we bring you from a 10 to an 8? And if we didn't do that, we weren't doing our job. And so hospitals were incentivized to use medications to change that number. Now, in looking backward, and if you really get in, there's a lot of interesting about where that came from and where that lobbying came from, and maybe potential politics behind some of that. But we know now that that's probably wrong. Pain is hard, right? It's subjective. I have very stoic Norwegian patients, not to stereotype, I can claim that too, very stoic, and their 10 is probably someone's 200. You can't measure it. It's not like blood pressure. It's not like cholesterol. We don't have this number. So that definitely plays into it, is asking your pain. As being a good patient, what's tolerable? So my patients in the ER, that's our second question. So we might still ask you, what's your pain level? Oh, it's a 10. What's your goal? Because I can't get you from a 10 to a 0. Like, that's not obtainable. You think about that fracture, the leg sticking out. If you tell me I want to be a 0, it's not going to happen unless we completely sedate you and send you to the ICU. But would you be happy with an 8? Can we work towards a goal of 8? And so having that conversation, and as healthcare providers, we need to get better at doing that. As patients, we need to get better at thinking about that and thinking about, is an increase better, but knowing what's unobtainable, or what, and I like it versus don't even think about the numbers. What do you want to be able to do? I'm in so much pain, I can't get from my bed to the chair. Great, that's our goal. Let's get you to a pain level where you're able to get out of bed and get to the chair. I don't care what number you're at. Let's focus on an attainable goal and something that we can better measure if you've attained that goal. Yeah.
I have 2 questions. The first one is, you said that fentanyl is being tweaked, and I want to know who's doing the tweaking of those chemical compounds. And my second question is real off the wall.
Oh boy.
A prisoner told me that he added lithium to his meth pot. What does that do?
Wow, you're right, that is a little off the wall. You warned me though. So the first question, tweaking the fentanyl. Lots of things, lots of people. We actually see a lot of our fentanyl come from China. And so chemists there that are affecting the structure. Again, lots of money to be made in this. You create a buying pool that has demand. They want to continue to use. Even if they don't want to, they're going to feel awful if they don't. And so, but we do see a lot of our fentanyl analogs come in from China. And then there's kind of a drug route, tend to be kind of through Chicago, through Minneapolis, up to kind of this region and all the way up to Duluth. So as in the ER in Duluth, I kind of watch the trends. What are we seeing in the Twin Cities? I got real nervous seeing this batch of heroin that was fentanyl laced, thinking, I bet, we hadn't seen it yet, but I bet it's coming, because that's kind of the pattern. Now the question about lithium in meth. People try a lot of different things. So lithium, if you're unaware, is a medication we use for several things. We can use it for depression. It's most commonly used for bipolar to help stabilize moods. I would think that someone might add that to meth in hopes that you would stable that mood. Now, it's going to work in completely different ways, and it's not something I would advocate for or think I would try. But in thinking about, I think that's probably what someone might be trying to do, is that they might be trying to take if you think about someone that's on meth, if you've seen that, they're revved up. They're going, it kind of looks like a manic episode, like bipolar. And so in that case, they might be thinking, maybe we can help balance some of that out. It's not going to necessarily be as effective because they work in different ways. But that would be why I would guess.
Our speaker has to get back to Duluth tonight. It's getting late. So
I could take a couple more
Okay,
questions.
all right.
We're okay. A couple more, though.
I have 2 questions. Hopefully you can make them quick.
Everyone's double dipping. Yeah.
I didn't know if you knew about the drug court a little bit and like who decides if someone can divert out of just going straight to prison and take that option, if you knew anything about that. And then also if you've looked at any of the data on the states that have either legalized recreational marijuana or medical marijuana, and if the data is any different at all in those areas.
Ah, wow, you stumped me. Those are 2 great questions. So I don't know a lot about who makes that determination of drug court. I can give you a name of a colleague of mine who is actually a pharmacist that sits on the Carleton County Drug Court, but I don't know exactly how that. I think it has a lot to do with prior and what your chances of recovering through that method and what your drug crime was in the first place. Your second question about medical marijuana and how that changes the overdose rates, I can't say for sure that I know that data well enough to speak on it. I can say that we have seen instances where our marijuana has also been laced with fentanyl. And so I would worry that if that use is more available and accessible, that there might be the potential that there'd be a poor supply in the sense that it wouldn't contain what we thought it was in the first place. But I'm going to have to look. Yeah.
Some people choose to manage their pain with legal marijuana.
Yep.
Like opioids, if that changes the data.
Yeah, I think it would really depend on where that was coming from. And you gave me a good idea. That'll give me work to do. I can't do it on the drive home, but I'll be thinking about it and looking at that data. Thank you.
Well, she asked my one
Oh.
question, so that's been the marijuana one. The other one, is there a statistic about how many patients that overdose that do it again? Repeat?
There is. Unfortunately, we know that if you've overdosed once, you're more at risk of overdosing again. And a lot of that relates just to the fact that we know addiction is a chronic disease. We know that we know that people go through treatment over and over. I work, again, in the ER, and I've worked with nurses that say, oh, it's so-and-so again. They've overdosed again. And they're hesitant to care for that patient. And I look at it as a bigger picture of we have a lot of patients that way. We have patients that have breathing problems like COPD that continue to smoke. We have diabetic patients that continue to not eat healthy. We have heart attack patients that continue to eat poorly and they're making choices. So we know that these patients have a chronic disease, and we know that because of that disease, they are more at risk of overdosing again. So we're looking at pathways to make sure, out of my ED, a patient that comes in with an opioid overdose, and they've hopefully received naloxone and have been revived, that we're giving them more naloxone to take home, knowing that they're at a risk. Of course, we want them to get into treatment and get to a place where they don't need to use an opioid, but knowing that that is a very difficult road. And so, and there is data, and I can't remember the specific number to see like what the average number, but absolutely, if you've overdosed once, you're at greater risk of overdosing again, unfortunately.
Well, I know I sure learned a lot tonight, so let's please give our speaker a hand for excellent presentation.
Well, thank you.